for the first time, Ultima really does what I've always wanted technology to do. Okay? So the creates outstanding results in many months, less treatment time. This is so huge for our profession. I'm going to talk as we go through the day. It really will help our profession grow if we can cut our treatment time, hide the best you can do and shorten treatment times. And that is so important for our profession to grow like we want it to. A very significant technology advance to help shorten treatment times with far less effort for clinicians, showing amazing results for patients' lifetime and truly helping clinical orthodontics. Those last two slides are really the bottom line of what we're going to talk about today. The revolutionary thing. I love these things. You know, I look at this and you think, how could anything like this work? Well, it does, and it's exciting. I never get tired of looking at it. The game changers. It is the game changer. Okay. Today I plan to first highlight a few of the many influences, and this is so important, is these influence that we have as we go through life and really learn, pick those things up, or it may come from a patient. But what I tried to do is really follow up on it. And if it was something that I thought might make me better, I spent whatever it took and collect the data to understand what potentially was really going to impact what I was doing for patients. So today I plan to first highlight a few of the many influences that help lead down the path to passive self-ligation. That was a huge step for me, and I'll show you here, because my first about 15 years in practice, I'm not very pleased with what I achieved, because they look fine when I stop treatment, but if you follow your cases 10, 15, 20 years later, you really see what you've done. And I lost a lot of sleep. So later we will then focus on why we developed the Damon Ultima system and why it is so revolutionary. I'm very proud of it. In my ortho residency in 1968 and to 1970, can you believe that? This is so far along. That means I'm older than dirt. But anyway, we treated our patients with twin brackets, and please, when I'm talking about, if I'm saying anything, problems they have with this or that, I never want to put anything down, because somebody has worked so hard to bring that to our profession, and I don't want to be guilty of that. And so please remember my words on that I'm not trying to throw anybody under the bus, so to speak. Okay? So treat patients with twin brackets and mechanics, trained to treat to the original arch form. I see people shaking their head. Oh. Trained to extract 65-70% of my patients. Rarely encouraged to minimize the application of treatment forces. We didn't really talk about that. And I had some great instructors that were trying to do the right thing, and I love them. But this is just what it was back in 1968 to 70. Arch wires were tied in with ligature wires and elastic ties, causing significant friction and binding. We know the heavier forces. I decided to set up a recall plan to follow challenging cases. This, I want you to, if you take this away of what I'm saying, is that if you have complicated cases, you really don't know how you've done. You get to the end and you say, oh gosh, I really did a good job. But you have to follow it for 10, 15 years to really know how you've done. Because some that look okay come back and said, hey doc, I need more of your help. And that really turned me upside down, and I learned so much from that. My plan also was to try to use the lowest possible clinical forces. That was quite obvious to me, okay? My cellular biology research, I worked at King County, got me involved in research early. I was in dental school, and in the summertime, I was at King County, and that really, King County Hospital, that really helped me because it opened up my brain, and I was in and out of surgeries, and I was looking at people, and I was looking at the research, looking at CT scans and all the things when we didn't have CT scans in our office. But I expanded, and made me curious, made me tremendously curious. Curious of how the magnitude of clinical forces could impact bone, tissue, long-term oral health in patients receiving orthodontic treatment. Like this is a good example, okay? Just something like this, you put it in your brain and it impacts you for your whole career. Now, will bone and teeth allow light forces of assist to move the third molar? You've seen this in your office. Can it move back like this? And you think the density of bone? There's the cyst. There it is. In 8 months. In 8 months. Without any change into the root. Very interesting. Let's look at this. I want somebody to stand up. Where is the upper left cuspid?
On the sinus. Left sinus.
Oh, what happened? Just a minute. This changed. Okay, good. There's the upper left cuspid. Now, what are you going to do with it? Well, let's look. There's that cyst. Look at the size of it. Okay? How much force is generated by a slow-growing cyst? What would be your treatment plan for it? Well, this gentleman that gave me these slides, he had the oral surgeon remove the cyst. I says, what else did you do? He says, nothing. Okay, let's just look here. What's interesting, you look, how does it know where to go? There's the pathway where the cyst was. Okay? Now, let's just watch. Here it comes. Here it comes. It's coming on the way down. There it is. Here it's coming. Isn't this fascinating? Here it comes. It looks like it has a brain, doesn't it? Here it comes, right here. But look at the root. It's beautiful. There's no damage to the root at all. And I look at this. If this can go 4 or 5 inches or 6, whatever it is, I got to do that with my treatment. Because here this cuspid is still perfect. And it's been on a real trip around the world. So if you really look at it, it went from here clear back to here. And from there, clear down to here. Fascinating, isn't it? That's what we want to do with our treatment. That's what we want to be able to capture. That's why I work so hard to create what we have. Is that we can get these forces down and we can do anything we want to. If we understand these things and really put them in your heart and your soul and your brain, it makes what we do so fun. Look at the health of the cuspid root and surrounding bone after moving through alveolar bone on the way posterior using very light forces. What cyst doesn't push very hard. Then taking the path of least resistant home, total pathway 4 or 5 inches is probably more than that. More than that. Very fascinating. It was one of the most significant influences on my thought process to create a very light biologic force bracket and arch wire system that can do this. That's what I want for it. And to make it easy for all of us. But in order to do that, the lighter we push and do this, and this happened very quickly, why, we want that to be part of our treatment. What we get, I want that to be in your brain. In my residency, great guy, Dr. Rydell was a brilliant clinician. He could bend wires better than anybody I'd ever seen. He would sit there and he says, he called me Dwighty Boy. He says, Dwighty Boy, all you have to do, on that case, and he'd look in there and he'd go, oh, here, put that in. I looked, oh yeah, I'll put that in. But anyway, what he decided to do is you couldn't graduate from the University of Washington program unless you got 3 patients that were treated at the university and they were out of treatment 20 years. Now, this is 900 plus. I wish I had a golf ball for every hour I spent in there looking at those cases. I spent thousands of hours. And when I went into practice in Spokane, I would get things that I wanted to compare. I would get in the car and I'd bring my family. They were young, and my wife, my dear wife, we'd go to U Washington, and I'd go back and I would go through all these cases again and meticulously look at them. And I would say, how come? Well, let's go further. I was fascinated, spent many hundreds of hours studying these patients' record. A major impact on my career. What I observed, nearly 900 cases, 20 years out of treatment, conventional braces. Now, there again, I'm not trying to point a finger at that. Please don't ever say, oh, Dr. Damon just threw such and such under the bus. I'm just showing you what I saw. Conventional brace, most patients were extracted and treated through the original arch form. Okay? 10 years later, research done, published, Dr. Bob Little, we were in the same residency together, bright guy. He took the time, and he'd been in practice in Seattle, and so he did an analysis. Only 30% were stable after 10 years. Only 30% were stable. Did you hear that? And after 20 years, there are only 10% were stable. And that is such valuable information. And it's not the only thing, but what happens to sometimes in professions, when they see something like that is so telltale, I really don't want to pay attention to it. Would you agree to that sometimes? So anyway, I asked Dr. Ray, I observed so many patients that had significant long-term bone and tissue problems. Has a periodontal study ever been done? He says, he was down looking at his desk, and he didn't look at me, and he says, no. I said, why hasn't one been done? Maybe they don't want to know. Isn't that interesting? Yeah. Brilliant guy. He could bend wires better than anybody I have ever seen in the world. And yet, that's what he said. I spent hundreds of hours evaluating treatment results from the study and compared them with my own. After I was in practice in Spokane, that's what I would just told you. I would go over and I'd take, sometimes 20 cases, and I'd go over and I'd compare what's there. And that's what got me thinking out of the box. I've got to make a difference here. Over the years, I also observed application of clinical force at any stage of treatment exceeding the biologic limit of the periodontal ligament and surrounding bone. Usually takes 10 to 25 years to show. I've already said, I'm saying it again because I want you to really put that in your brain and really use it. A very big deal to think about. How many of your own cases, how many of your own treated cases have you carefully evaluated many years post-treatment.
Less
I want you to think about it. Because if you don't know, you don't really know how you're doing. Because when you finish, you say, oh boy, I really did well on that. But I can show you some that I treated, and I looked at him, and I said, you know, you better go back and be a general dentist. You know? So we have to understand how we have to evaluate these to really know what we're doing, okay? This is so critically important. Okay. I want to just take this, and this, we were talking a little bit about this. This is my family. This is my son. This is Lloyd. We have 7, we'll have 7 orthodontists in my family. Isn't that wild?
Yeah.
I'm so proud of it because we love it because we love people. They wanted me to be a heart surgeon, but I finally decided not to do that because they're asleep when you're working on them. You don't get to know them. So anyway, and this little pumpkin just graduated from TCU. Yeah, straight A student, just brilliant. And the mom, and this is my son, he's an orthodontist. We practice together. I love him to death. One of the finest people I've ever known in my life. Here they are.
Oh my God.
Okay, this is Ella that's just graduating. Here's the one and only. He just shot 69 in a golf tournament.
No.
Okay, let's just take a look. Now, what I wanted to do, and this will startle all of you because it's so fascinating, is that I said, I have to figure out when the lower arch, when our upper and lower arches are full grown. That makes a difference, doesn't it? Yeah. I would love to put a vote out and have you write down when it is. Well, this Cowboy Logan, age 4. And here's age 2. Sweetie Pie, I love her to death. And look at what I did. I took wax bites and heated them and put them in because I didn't want them to choke on impression material. And then they bought it, but you know how I got them to do it? I put a big refrigerator in my office and I had all kinds of ice cream in there. So if they would help me with this, they got to choose. And oh my gosh, that was big, and there'd be a line out there. That got to be in my overhead. Yeah, you know, it was really fun. But what I want you to do, let's just take a look. I figured out how to measure. This is Logan at age 4 back. Exactly the same. Exactly the same. Okay? The cuspids. Not about the same, exactly the same. Isn't that wild? Okay, my little sweetie pie. 2 years old, cuspids exact. If the muscles are in balance, it's done at 2. Put that back there because that will influence your thought process. But see, this crazy project that I went on helped my thought process tremendously. And I used it a lot, and I was not afraid to do some things, and we'll show you some of those things a little bit later. But anyway, 19.5, I just stunned that it hit it right on the... Now, this is my sweetie pie, my daughter, and she's one of the world's best designers. She's been in the center of all these things, and I'm very proud of her, but she's severely potty trained, just like her father is, and tries to do everything the best, you know, and I'm so proud of her. But see this guy right here? Very big head, no brain. Very big head, no brain. At that time I was 6'4", okay? When she was 2, same, exactly. Okay? That's my son, my orthodontist. We practiced together for 10 years. Great, great guy. 6'1", 6 feet a half inch. Exactly the same. Pumpkin pie. 2 years old. Look at those eyes.
No.
Yep. Oh, wait just a minute. Where did they come? Anyway, the same. I showed you that previously. Exactly. Isn't that's really fun. Now, you kind of go around, and I read articles. I kept busy. What Frankel did. I want to just go through this. 1966. Really, the theory of concept underlying the treatment with functional correctors. Bottom line, if the patient's oral musculature is in good balance, the dentition will vary close to the same size and shape as the natural arch form. This should tell clinicians in the world to treat to the natural arch form in most patients. There are some that are bigger, African Americans. There are in some parts, I don't want to start down that road because we could spend an hour on it. But anyway, I recently read that 70% of clinicians still treat their patients to the original arch form. I don't know if that's true or not, but I read it in the literature. Okay, Frankel. Look at this horrific thing. I don't know, he must have had a nightmare when he designed this thing, but guess what? If they wore it, it worked. And I'm sure some of you may have used this. But if you look, Frankel correctors do not push on teeth. They just sit in here. Now, here's the shield out here, shielding the muscles of the face on. And this just is holding the whole thing together. But here the tongue has to wake up, and the tongue has to start pushing out, doesn't it? Okay? But you see this? See the space in there? It's hard to see. But that space, and it just starts moving out over time. Sometimes it takes up to 3 years to get this to go. But the biologic system wants that. And it's very interesting. The Europeans gave me over 3,000 records of Frankel's, and I went over every single one of them with a fine-tooth comb. I learned a lot. The consistency form, and that's why when I originally came out with passive self-ligation, I called Let's Treat to the Damon arch form. I took it off in about two months. It's not the Damon arch form. It's the natural arch form. It's the natural arch form. Okay? But here, this is missing teeth and everything else. Not a very good example, but that's what's in the article. But I want you before, after. We'll just go through. Look at this. This is with Frankel's cases. Okay? Not prone to relapse. Why? Because it forms the natural arch form. I think what I'm trying to do is just validate what we're talking about with why I have bottom line and treated to the arch form on most of my cases. But look at this. Isn't that interesting? This is even hard. I mean, there's not many teeth in there, but anyway, there it is. Fascinating, isn't it? That's why they started teaching the way we did. Teaching to the arch form. So, when I started my practice in 1960, I tried very hard to apply the lightest forces possible because that made sense to me with the things that I had seen. Unfortunately, we were taught to treat to the original arch form, and people were trying to do the right thing, and I love my instructors and all that, but That was a toughie. We evaluated my own early cases many years post-treatment. Many showed very poor stability, usually exhibited very significant periodontal issues. A quick look at what encouraged me in 1988 to start designing and developing a new bracket system called passive self-ligation. Okay, this gal. This is very hard for me to show you because I did the very best that I knew to do, and it's a disaster. I should have been sued. Don't take that to some attorney, but it's the truth. And I cared about this gal and her family so much. It haunts me to this day. Just talking about it, my blood pressure's gone up huge because been careful about it. 16 years later, this was my final tipping point. I said, Dwighty boy, you have to change what you're doing or you have to do something else. I don't think that's hopefully coming on too strong. It was just my talking to myself because I knew there had to be a better way. So here's this gal. To extract this, that's what I was instructed to do. And I anyway, let's just go through it. Final. The lower. Final. Look at how tipped in it is. Oh, there's no way that's going to be healthy. Those in like this, you look at this 15 years later, and it's a nightmare. Okay? The only way we can know if your orthodontic final results are stable and successful to follow your tough cases. Please, if you don't get anything else from my lecture, pick these and follow them 10, 15, 20 years later. Look at this. Look at this. Look at the tissue. You don't see it as much here on this screen as you do. But look, it just wipes me out. It wipes me out. Very sad. That's why I said, Dwight, you have to figure out something. Fox and these results 16 years post-treatment. Look carefully at that. And this woman was immaculate. She took care of, she lives in eastern Canada. And I did everything I could to get her. I was going to pay for her flight. I would even fly her private. Fly her out here, and I wanted to retreat her for nothing. I retreated hundreds of my patients for nothing. And I bought implants. I spent thousands and thousands of dollars trying to do what I was doing what I thought was right. But I'm just sharing it with you, and it's hard to sit up here and say, well, it's easy for you to say, well, I wouldn't do that. Well, have you really looked at your patients 15 years later? Okay? Look at this. Look at the lower. No chance for that to be stable. And then it wasn't here. You take 4 buys out. Was it stable? No. Crazy, isn't it? Second molar, gone. Fortunate I didn't have a CT scan yet, because that would have really talked. But I got one at the hospital. Look at that. Long term, those don't do well. And that's why I was told I was the first person in the United States to buy a CT scan. And man, did I use it. And I followed my cases. I put a special deal and I followed hundreds of cases. This is such a strong lesson. Okay, and this gal, what a nice gal, and I tried to get her to come fly private or whatever, and I do it, and she was raising children. She just couldn't do it, and I sent her Christmas stuff, and I said, if you ever will come, I'll go back in an office and I'll treat you. But look at that. See how it tipped in? That was entreating to the natural art and to the original art form, which is being taught in a lot of places, and that's all I'm going to say. I don't want to beat anybody because who's teaching it is trying hard to help people. I know. But I'm just saying that this is what I have learned. 26 degrees and in cross anatomy before I ever went into practice. It's supposed to be around 10 degrees. By narrow arch form, extract patient, and it's really impossible to achieve proper posterior functional occlusion. There it is. Cross anatomy, 1992. Okay. I was a lab man for one of the world's best full mouth reconstruction guys. And man, did I learn a lot from him. Because he worked so hard, even though and when he full mouth reconstruction, he would prep everything, and he worked so hard to get things up. And that really impacted me and helped me tremendously throughout my career. He focused on treating his patients to the natural arch form as best he could, this transverse curve, and this functional conclusion. I wish all ortho residencies were teaching to treat to the natural arch form, allowing far more non-extraction cases achieving ideal functional occlusions when the evidence is so overwhelming and critically important for long-term patient health. Okay? And here's, you know, you don't have to look very far, showing how that more horizontal front not tolerated well. No, not at all. And yet, if you treat to some of the things that some people, I'm going to stop there, okay? Important. Okay, my 1988, why are you sitting there and say, yes, Dr. Damon, you're talking, why didn't you do something? It's been 18 years. Why didn't you do something? And I said, I need to change how I'm treating my patients, and you can read that. The natural arch form, taking patient care to a higher level in a shorter period of time. This is the gal. I must reduce binding and friction. We must be able to apply far lower treatment forces. We must be able to treat. This is before I really understood things. Natural arch form, not the original arch form. We hope natural arch form will help improve airways. That was when it started to creep into my time. The airways was a big deal. We hope treating to the natural arch will help outstanding functional occlusion. We must be able to treat more patients non-extraction. More of these very important issues later in this presentation. Okay, I want all of you to know before we leave this twin bracket patient with these very sad results. After I developed passive self-ligation, when I went back, and at no charge, I offered to treat anybody that would be willing to come in, and I retreated them for nothing, and I bought hundreds of implants, of which I had extracted. But you know what? The only way I could sleep, kind of, sort of, but that's what happens. And when, you know, and so very hard to show this, but I want clinicians to learn. That's how we learn. Okay? So please don't leave and say, oh, Dr. Damon is really putting people down and doing it. I don't want to do that. Not at all. I just want to help us all get better. And that's why I'm laying myself out and showing this, and you say, oh, why is he up there talking? This is terrible. But we got a little better. Okay? If we have more time, I would show the many hours of very compelling evidence and research that I either created, collected research from around the world to support making this significant new to totally change how we clinicians could treat our patients. If you're wondering why I didn't start developing PSL earlier, this is very important. In the early years of my practice, I always tried very hard to first be a good dad, a good father. That was the most important thing in my life for my kids and family. And that's why I didn't have anything else to use at that time other than going to some of Frankel's stuff. And we could go on, there's other things, of course. But if you're wondering, that's why I waited until then. And boy, I says, now the kids are old enough that I can start. Well, when you do these things, it's a 10, 12-hour day every day. You go to work, but then you come home, you don't sleep much. So I didn't know that was coming up. I didn't sleep much when I was inventing design. I started testing new PSL in my office in early '92. I want to thank many people. Damon Passive Cell was introduced to the profession in 1995 after we had tested it for a while. Very proud of PSL, what it's done for our profession, the positive impact. It did not solve all clinical problems, but it was far better. But I want you to say it did not serve all, and that's what brought me back out of retirement. Not retirement, I never really did that. So when I started testing passive self-ligation, in 1992, very obvious that the PDL does very well. You've seen pictures like that, but really look at it. That just blows me. I've got that picture in my brain so much of that. That's what we work with every day. And I want to take great care of that. Everything I put in, I think, how is that going to do? How is that going to do? So, why light treatment forces? You look here, bone, PDL, tooth, Use biologic treatment forces, treating the natural large form, the same thing, superfunctional collusion. So critically important, patient health for the long term. Crown jewel of clinical orthodontics. Take great care here of what we're talking about. All right, use biologic treatment forces, treating to the natural large form, superb functional occlusion, patient health for the long term. Orthodontics can and should be far more than just straightening teeth. I hope you will take this away because we're going to talk a lot about it. It's not just, yes, that's a big part of it, but it's not all of it. There's a whole bunch more. I look at it totally different. So much more biological. What we do are the real big things that we can do for about 65% of our patients. And if you understand what you're doing for patients, going to a whole nother level. And boy, does it make it fun 15 years later when you're going to get there sometime. And you go and look and you think, hey, I kind of knew what I was doing. And you don't have to go through what I have done. So, medical CT scans. All right, now let's start. I did a medical CT. I followed, when I started passive self-ligation, I decided that I was going to take, they didn't have CT scans. And so I paid a couple grand a patient, took him to the hospital, and took CT scans. I wanted to see what was going on. So, basal bone, here it is. You know this, if you got a CT scan, this basal bone down here and what's going on up here. Look at it, metal foramen, that's about where basal bone stops. And you have alveolar. The patients were part of my medical CT scan study I did in 2003-4 showing mandibular jaw, basal bone and the red line. Amazing proof. All are similar in size and shape except class 3s. Did you hear that? Okay. I picked these because of the 15, 5'2", 5'9", 6'5". So we'd have a good height difference. Okay? Now this is all the same size, Do they fit? Yeah. Spot on, aren't they? Okay. Most Caucasians in the U.S. and Europe have mandibles that are usually similar in size and shape, except Class 3s and African Americans. I am told, and you can tell me, that Asians also have. You got some bimaxillary protrusion, and I realize that. And I would like some of your cases to show, because I don't get to treat that. But I know that, and I'm going to show you what I do on those kind of cases, because on some of those you got to extract. Am I wrong?
No.
Yeah, otherwise you get things together, right? Okay, this gal. Okay, I'm going to go through it. Look at her. Now it looks straightforward. That is Dr. Damon. This is one of the hardest cases to treat I ever tried. Her muscles ruled the world. She had about as bad a sleep apnea as I've ever had in my office. Her mother was so afraid of what was going on with her. Why crowding? She's really strong. And it looks easy. That's not a tough case. But that's why it's here. Okay? Mother stated, my daughter has very severe sleep and airway issues. Okay? Straightforward. This is a whole hum case, but it isn't to her health-wise, is it? He said, part of orthodontic treatment should be focused on giving the tongue room and a second chance to move forward and laterally, lifting vertically, helping to open the airway. I want that tongue to be my greatest friend. And that's why I don't want anything in the way. I want to have that in there and have it working together and watch this thing bloom. Come on, it is so fun. When I had a really tough case, couldn't wait to get to the office when I knew they were coming in for the check, because it was so fun to watch it happen. It's obvious that many patients that need orthodontic treatment also have airways, and that's why I'm trying to say in this that ortho is more than just straightening teeth. It has been stated in the literature that over 60% of the world's population has some type of airway issues. 60%. I don't know if that's true, but I think it's probably pretty close. I'd love to hear your comments when we get through this. Okay, here she is done. The strong recommendation was using passive self-index and ultimate bracket tech. These, I don't want anything in the way of the tongue developing a new muscle balance and function. It is so fun. With passive self-ligation helped, but it had some problems that finally got me off the golf course and started to work on Ultima. Okay? There it is. No more snoring at night. Sinus infection. I have much more energy. Orthodontics changed my life. I'm happy. Here's the look at the see. On the money. Look at this. I wouldn't hook this up this way now. This back a long time ago. I would have done, well, you can see what exactly what happened. Here, I would put this out here and then go over the top to start, because you got better range here. You don't have to push any harder, but it works better. Would anybody agree?
Yes.
I said something you agree with? That's good. That's good. Yeah, that's good. Airway problems, soft. Okay, lower posterior anterior uprighted. A new balance. See, this case, yeah, crooked teeth. But the big thing was all the airway stuff, muscle function, how the tongue worked. All the airway, how it all worked together. And that's what I have learned in the last 20 years of my practice. That's what really impacted me. Come on in, tongue. We made room for you. Hello, airway. What fun. Big deal. Airway under control. Upper. Oh, good airway. Okay. Don't overpower. You know, the tip on achieving more bodily movement, the tipping in the max area, don't push too hard. Just be patient. Be patient. Just a little push and be very patient. Just keep it going a little bit. And the whole thing will go out. I'm going to show you a case that went out 14 millimeters on its own. And it didn't tip one speck. Okay? I even learned something from that. You know? Isn't that interesting? Okay. Let the tongue help create arch width as it establishes itself in the normal position. This is so big. The tongue, the muscles of the face, and all of this go together. The airway working together, helping the teeth straighten. That's where my brain went the last, and I thought I really became almost a doctor. You know, almost, as I said, almost a doctor, because I was treating people, not just straightening teeth. I was really biologically trying to take their life to a whole nother level. Okay? Look where it was. Look at this. This is dynamite. If this gal was left this way, I could show you look, she would be a disaster in her for later midlife. But this is what we did. Poor airway issues gone. On the money. Summary: the upper and lower posterior width, the natural arm helps create proper posterior functional occlusion with a positive impact on airway, tongue, and facial muscle function, creating stability long term. Muscles are in balance. Out, pushing in. This is, you know, Krause's stuff. You go back and read other people saying 8, 10, 12. Now I have a CT scan. I was the first in the United States to have a CT scan. 10. Right on the money.
Yeah.
This is when we started. Now, this is really important. I want you, if you're asleep, try to wake up. Okay? This is a really important slide. A very important slide. Why? The impact of basal bone. Why is the upper vertical in exactly the way it's supposed to be? The basal bone's clear out here. So it lets this, and I'm going to show you case after case where you take it out 12, 14 millimeters, and it doesn't tip if you don't push too hard. It goes out bodily because the tongue's on the inside saying, come on, let's all go together. Okay? So this handle here, but down below, it's a whole different enchilada. Down below, this is basal bone, and it's right, the root tip's right there. So all I'm going to do down there is upright. I don't torque it. I upright it by putting width. If I put torque on it, that's trying to move. If you put torque in it, I'll show you in a minute. You're trying to move this off the basal bone. Isn't that interesting? Look at that. I just had to watch it. That's all. See that alveolar bone? Right on the money. Easy. Very easy. Teeth uprighting due to arch width, not torque. All right, now, and what I just want you to know, if you, that's why when you go to Ultima, we don't have torque in the buys. We have neutral. This is why. We wanted to just gently push it out, but I don't want it tipping it. Does that make sense? So, if I tip it in upright, this is what it wants to do. It's not going to do that because the body won't let that thing happen, but that's what is really going on. Shows why tipping is desired, not bracket torque in the lower posterior arch, okay? Amazing. As the torque starts repositioning, so I do not want anything. How many times have I said anything to get in the way of the tongue, helping both the upper and lower arch shape and creating posterior width? Thank you, tongue, for your help. A very, very big deal. Big part of orthodontics. And I keep saying that. Airway, great functional includes stability for the long term. Now, mom's here. Just read that. Debonding Day, mother's comments. What is so exciting for our family is that Brittany not only has this stunning smile, but she now is a very happy person because she no longer has severe breathing and sleep issues. She has also become a brilliant student. We are very, very grateful. I got a real good hug from Mom and from Brittany. And boy, did it mean a lot, you know? PSNL, very amazing Damon Ultima, Orthodontic Treatment Canada should be. I keep saying that because I want you to take that away. Okay, this is a cool case. Some of you see me. This has taught me so much, so much. Have you seen this guy?
Yes.
A few of you have. What's going on? This guy, Christmas time in Spokane, I'm downtown, having a great time. And here comes this guy, and here's this woman, she's in her late 80s, and her arms are full of gifts for her great-grandkids. And she's coming, and she's dropping them on the street and all this stuff. And he goes across the street, and I'm quite a ways away from it. And he turns around, and he goes running out on the street, and the red light now, and she's got all this stuff. And he's picking all this up, and he gets into his arms and going like this, and she's kind of slowly, and I watched them. They came in and they walked the whole block, and that was her car. He put everything in, and she hugged him, and he came back down, and I waited all that time. It was very emotional for me to watch this, and he was standing going, and I went over to him, and I could see him. He was a half a block away when I first looked at him. And I said, that guy has the worst airway I've ever seen. It's a disaster. It's a disaster. So I talked to him. I says, yeah, Steve. I said, that's one of the nicest things I've ever seen somebody do. It really touched my heart. It was tears in my eyes. And he says, oh, I just had to do that. And I said, well, do you have time for a cup of coffee? I'd love to buy you a cup of coffee. So we went over. We sat down and having a coffee. So I'm listening to him. Worst breathing I have ever heard in a patient. He's sitting there, and we talked for quite a while before I wanted to put the one-liner in. And I said, Steve, do you have any trouble breathing?
Mm.
You know what happened? Tears shot out of his eyes.
Oh.
It didn't run out. It shot out. I've never seen that happen down on the table. And he started crying, and it he says, my life is a nightmare. It's a nightmare. I can't sleep in my bed. I can't drive my car. I'll go to sleep. He went through, he started talking, and I could, it's very humbling, but I looked at him and I said, and after a while he kind of settled down. He says, what do you do? And I says, I'm an orthodontist. And then he broke out again, started crying again. And so I said, Steve, and he told me all about his life and how he wasn't enjoying his life and all this stuff. And I said, Steve, I said, you were so wonderful to that patient. I'm going to give you a Christmas present. I says, will you please come to the office? I want to help you. So away he comes. Now, when I didn't stick my hands in his mouth, but when he came to the office, these things were dancing around in his eyes. They were flopping. There was a big part of the posterior segment. It had no buccal bone at all, none, zero. So, 52 years of age. Look. Got a little up here. Isn't that wild?
Oh.
Look at his eyes. Those are the worst eyes I think I have ever seen in my practice. The upper and lower teeth are exceptionally mobile due to the very, very significant bone loss. Look at the arch form. Now, with no bone, would you treat that kid? It was a gamble. But he was doing so poor. What else do you do? And I told him. So anyway, here he is. Look at this. Is there any bone there? Look. That's more than most. Again, severe crowding, upper posterior teeth. All right, same thing that we talked about before. Basal bone up here, down here. All we had to do is up this floor, and this gives a room. Okay? But his teeth look so bad, I thought, geez, I don't care what I do, they're not going to look very good. But anyway, the whole point here was to help his health. That was the biggest thing here. But look how it was clammed in. Isn't that interesting? Okay. There he is. There's a new guy.
Hey.
Now, it's not very pretty teeth. But even look how isn't that interesting? Orthodontics can be a lot more than just straightening teeth. How could we possibly upright posterior sit starting with a very little or no alveolar buccal bone on many teeth? Come on in, tongue. We made room for you. Hello, airway. Severe airway issues. Look at the eyes when we started. You see why? I mean, it just jumped out here half a block away in Christmas, and I said, I got to help that guy. I got to help. That's what we ended with. Here he is. Just look around and take it all in. 14 and a half years later. Now, the hardest thing for me was to get him to come back.
Yes.
He leaves. He leaves and he goes home, and I'd stop by my office and I had to go out of my way. I'd go on and knock on the door. I knew he was there, but he didn't come to the door. And this went on for several years. And I thought, gee, did I do something? And he didn't. And I finally ran into him downtown. Couldn't get away from me. And so we reestablished. And the reason he came, he lost his retainer, quit wearing his retainer in 6 to 8 months, something like that. We'll have it here. Okay? And this is when we finished. And he knocked that off. Here he is, 14 and a half years later. Now I want you to look. He's never worn his retainer for 14 years. And look. Isn't that amazing? The muscles, see, for this guy, was worn straight in his teeth. That's the point I'm making. It was so fun. It was so fun to see this. He and I hugged each other, it was just so fun. Going from here. Excuse me. It's not great. It's not a beautiful case. The teeth aren't beautiful. But he's a new man. And that's why I'm showing you the upper. Come on in, Tom. The airway issues are gone. Okay, now let's look at him 14 plus years later. Look. Interesting, isn't it? I see your head going like that, I think it's so interesting. And he even broke the wire up there. I would never have accomplished this, but this with what I used to use. Here's medical CT scans. It's hard to see this. I wish I've spent many hours looking at it. I said, okay, Stever, I want you to take this home. I wanted you to take it home, and I want you to write down, how did your life change after having braces? And he got brought back in a couple of weeks. We went to lunch. My very, very severe sleep apnea and airway issues went away. I always had to sleep in the chair my whole life, adult life. Now I sleep in bed. 3, my overall health has improved so much, I'm not sick all the time. 4, my wife calls me the Energizer Bunny. She says I can't keep up with it. She can't keep up with me. He says, boy, is that fun. My wife has always had to drive me to work because of our fear of me falling asleep at the wheel. It was that bad. Since braces, I now drive a car without fear of falling asleep. My speech has improved so much, my friends say I don't mumble anymore. I have become a very active person. One of my hobbies is mountain climbing. Climb Mount Rainier, that's outside of Seattle. 14,409 feet. He climbed it at 67 years of age. Loved it. Isn't that cool? I just love it. And he grabbed me and hugged me. It was just so terrific. Just so terrific. I'm so grateful to you, Dr. Damon, for changing my life. How lucky we met on the street corner that day, and you invited me for a cup of coffee. Are there other things that are critically important besides just straightened teeth? Look, I keep saying it, don't I? There's a reason I do it, because my life, I've added that to what I wanted to think about in my practice. But look at his face. Look at this. This guy is a different person. And that's what we can do. That's what, to me, is ortho, is the next step. Not for everybody. A lot of them, we can just go in, straighten teeth, and that's it. But boy, to know how to do this and to have technology that you can do this, what a gift. And I'll tell you, usually when you do this, people are sending people from everywhere to your office. They say, you're more than a wire bender. They wouldn't say a wire bender, but you're doing other things. This almost makes me cry with happiness because it means so much. Okay, treat patients to the natural art form. damon1 have dramatically lowered the need for patient extractions, but most of the time, very good treatment plan for long-term patient health. However, with different patient genetics, like where a lot of you practice, you got faces and all this stuff, and I recognize it. I didn't know that until, actually, Steve, you kind of opened my mind to that. Can you believe that?
No.
No?
But thank you.
Amazing. He and Mike, love him to death. But it's, however, with different patient genetics in some parts of the world, there are still a few important times to extract for long-term patient health. And I'm sure you see it. Face-driven, extracting for the face, biomax, I don't need it. Here's a gal. You may not want to do what I did, but it changed her life. Okay? Look at those lips. That's the same gal. That's why it's fun to go to work. Can't wait to get there when you can do this. And now with Ultimate, holy mom, if I was still practicing, I mean, okay, but look at her face. Look at. I mean, it's just so fun. The profile isn't compromised significantly. Uprighted, had that, or a third, uprighted. Very beautiful smile arch. A major impact of arch shape and width, even though this was an extraction case. Now, what I did, because there was movement up and down because of extraction, I fit a wire to it so you could really see what was going on. Does that make sense? First bite, extracted, and then I put one over the top. That's what we did with the arch form. Okay, that's why she looks so good. We didn't compromise, even though she had this fullness and all that. She's a beautiful gal now. And yet she has airway, all these things that we've been talking about. And it's just, I run into her now and she just is so fun. Such a nice gal. But see, I couldn't really say because this has moved forward because the bye's out, but I just kind of showing what we actually did. And going into smile there. Extracting the face, but protecting airway. My life has totally changed since braces, and now the boys want to date me. She says, Dr. Dave, yeah, I need 2 folds. Such fun to be able to utilize very outstanding treatment technology and be able to treat patients very high level for a shorter time. This is just a straightforward case. But I love it that this, when you have great equipment, I did this with passive self-ligation, but now with Ultima, this is just sitting there. You can build your practice so big, particularly if we had Ultima, if we had the Clearwood. And we'll talk about that. We hope we get there. But you can have, because people don't want to go through 2 years of treatment. If you can give people a superb, as good a good treatment as you can in your 7-8 months, you know, you're going to have to put a double swinging door in. You know, because here's a gal. Okay, you say, well, that's no big deal. But you just look at it. This gal came from Seattle. She saw people, and she'd heard about what we were doing in Spokane. It's 300 and some miles over. She saw there's some very good orthodontists in Seattle, great friends of mine. And you look at what we had, but she wanted it, and she came over, and I said, you bet we can help you, but you can see how tipped in and all this. How long would it take to treat this? Got to fit everything together. Airway and tongue issues. A Seattle call. Here she is. 6 appointments. You know? That's pretty cool. This gal, you wouldn't believe how many patients she sent from Seattle to Spokane. And that's what I want for our profession with Ultima and having clear brackets. That's what I want. I want you guys to be, and gals, to be so successful that in just having so much fun. But this girl, she says I attract too much attention now. I never realized I could have such wonderful results so quick. Okay, these next slides are very compelling. Endorsement using passive self-ligation before we got to Ultima, and then we're getting close to that. I wish we had time to show how unbelievably stable and healthy all of those 15 cases were. I didn't handpick, I just picked something I wanted to show you, but it's amazing. When I did the medical CT scan, before I bought my own CT scan. The last patient I plan to show you from my passive self-ligation study with medical CT scans to evaluate bone responses. That was one of the first patients treated in this study in early 1993. This is when I just started using passive self-ligation. So I was learning a lot and going a lot different. The members in my orthodontic study club all felt there was no way that I could treat this patient without extracting teeth, or if I tried to treat non-extraction, teeth will never, never, never be stable and probably be jumping out of Cody's mouth. You know, so it said, so we had a big bet. Great guys. We were in a study club. We had more doggone fun. They really gave me a lot of heck. This, I would never do this. Never do this. But anyway, why treat Cody non-extraction? Because I'd learned all this stuff that I've been talking to you about. And he had all this stuff big time. You couldn't see it in his eyes, but he had it. So I wanted to do for Cody what I'd do for my son. Or to me, if I could look at my own. So anyway, here's Cody. Okay. 13-4. Now, I didn't want to extract Cody due to his very significant airway and sleep apnea issues, his profile, narrow arch form, and final functional occlusion. His lips can take something, but I just couldn't extract. Now look where we are. cuspid down in front. Now these are the first passive self-ligation. These things would fall off. I knew we were on to something. We couldn't really make it to the standard that we wanted. But man, I could realize, because look what's happening. Look at this, looks like a molar bracket. I mean, this is back. We had to come a long ways. I've already breathing better at night, he says. It's coming. 7 months. Okay? Look. All right? Is that fun? Do you like that? Yeah. So easy. So easy. And now with Ultima, because it does most of the work for you. If I had Ultima, I'd still have all my hair. No, really. Because he used to worry about this. But look at this. $14 millimeters. Okay, yeah, remarkable. 14 millimeters. Guess what? I never touched them. They went all that way on their own. Isn't that interesting? Why didn't I touch him? Because there wasn't any room up there with the way his jaws were, and I didn't need to. It went all this way because the muscles were in play and there was nothing in the way. And it made me look like I knew what I was doing. But really, it's just you get it set up and let it happen. Second molar, 14 millimeters. Look at this. It's just fantastic. I'm just so proud of this. And